After getting appropriate health history, I will perform hand hygiene. Introduce myself to the patient and identify the patient with two identifiers, name and date of birth. My lung assessment will start with inspection, palpation, percussion. I will start with the anterior chest and then go to the lateral chest and the posterior chest. While I inspect my patient, I will look for any signs and symptoms of cyanosis, which can be peripheral or circumoral, and also look for signs of cyanosis in the chest. I will look for any use of accessory muscles, and also the use of accessory muscles can be supraclavicular, intercostal muscles as well. Now I will also look for the movement on both sides of the chest wall and see if they are rising symmetrically or not. I will also inspect my patient's spine and its configuration. I will look for the posterior and the anterior diameter. In this case, the anterior and posterior diameter for my patient is 2:1, which is normal. After completing my inspection, I will palpate my patient's trachea, and then I will go downwards. I will palpate to look for if there is any tracheal deviation in my patients. In this case, there is no tracheal deviation and the trachea is at the midline. After that, I will assess the thorax and palpate it for any crepitus, tenderness, degree of symmetry, and tectus fremitus. I do not feel any crepitus, or the patient is not complaining of any tenderness. Now I will tell the patient to say 99.
99, 99, 99, 99, 99.
So I do hear the tectus fremitus, the vibration. I do palpate the tectus fremitus. After that, can you put your hands up? Feel for the axillary lymph node, which are not inflamed. After that, I will palpate for the supraclavicular lymph node and infraclavicular lymph nodes, which are not inflamed. This completes my assessment for palpation. Now I will percuss my patient from top to bottom. I'll start with the anterior portion, and then I'll compare with both sides. In the lung field, I should hear for resonance. After percussing the anterior portion, I'll do the same for the lateral and the posterior portion. Then I will auscultate the anterior portion of the lungs for any adventitious breath sound, and also listen for the normal breath sounds. I'll start with the apex of the lungs. Take some deep breaths, comparing with the other side. The lung sounds are clear to auscultation. In this case, the vesicular breath sound is heard throughout the lungs field, but the bronchovesicular sound has been heard over the first and second intercostal space anteriorly, which can also be heard in between the scapula. The tracheal sound is heard over the trachea, and the bronchial sounds is heard over the manubrium, which I can hear clearly for my patient. And there is no signs of abnormal breath sounds, for example, whistle, crackles, rhonchi. Can you turn around? Now I will start with the palpation for my patient on the lateral aspect. I will look for again for any crepitus, tenderness, and also palpate for tactile fremitus. Can you see 99?
99, 99, 99, 99, 99, 99.
The tactus fremitus is normal. After that, I will percuss my patient's lateral chest and also identify the diaphragmatic exertion. For diaphragmatic exertion, I will tell my patient to take a deep breath. Can you take a deep breath? Take a deep breath and hold your breath. I'm looking for the dullness in the diaphragm. Now I'll mark this place. Exhale. Take some deep breaths, in and out. The next breath, exhale and hold it. Breathe out. Breathe in. Normal. So the diaphragmatic exertion has been 2 cm on the right. Now I will continue the same procedure on the left. Take a deep breath. Exhale. Exhale and hold it. Two centimeter again, which is normal. Breathe. Now, I will auscultate my patient's posterior lungs and also the lateral aspect of the lungs. I'll start from top to bottom and compare the both sides as I go down. Deep breath in and out. The lung sounds are clear. I will also auscultate the lateral aspect of the lungs. I will also hear for bronchovesicular sound in between the scapula. Which is normal. The vesicular sound for my patient for inhalation was greater than exhalation, and the bronchovesicular sound, the exhalation was greater than inhalation, and for bronchial sound, the inhalation and exhalation was equal. With this, I am completing my pulmonary assessment.